This conference will now be recorded.
So good morning everyone. Today we are going to deal with the three topics which are from the same chapter, that is cell injury and adaptations. So we are going to discuss about MONCKEBERG sclerosis, calcinosis and dry gangrene. So first topic is dry gangrene. So this is the definition of gangrene. The gangrene is a necrosis of tissue associated with supraadded putrefaction, most often following coagulative necrosis due to ischemia. Example in gangrene of the bowel and gangrene of the limb. So gangrene is nothing but it is a necrosed tissue with superadded putrefaction. So there are mainly two types of gangrene, dry gangrene and wet gangrene. Dry gangrene is, this form of gangrene begins in the distal part of a limb due to ischemia. The typical example is the dry gangrene in the toes and feet of an old patient due to severe atherosclerosis. And the other causes of dry gangrene foot include TAO, that is thromboangiitis obliterans, seen in Burgess disease, Raynaud's disease, trauma and ergot poisoning. It is usually initiated in one of the toes, which is farthest from the blood supply, containing so little blood that even the invading bacteria find it hard to grow in the necrosed tissue. So the gangrene spreads slowly upwards until it reaches a point where the blood supply is adequate to keep the tissue viable. So there will be clear cut line of separation between the gangrenous area and the normal tissue, normal viable tissue which is having adequate blood supply. So this is the gangrene foot, which we can see the black colored mummified area. It is because of the devoid of the blood supply, ischemic area. And we can also notice the line of separation between the normal tissue as well as the mummified tissue. Here we can, these are the pictures I picked from the internet. Here we can see the black colored gangrenous mummified tissue and normal healthy tissue, and there is a clear cut line of separation between the gangrenous tissue as well as the normal tissue. So morphological features: grossly the affected part is dry, shrunken and dark black, resembling the foot of a mummy. It is black due to liberation of hemoglobin from the hemolyzed red blood cells, which is acted upon by hydrogen sulfide producing bacteria, resulting in formation of black iron sulfide. So the black color is because of the deposition of the iron sulfide. And the line of separation usually brings about complete separation with eventual falling off of the gangrenous tissue if it is not removed surgically. So there will be spontaneous amputation if it is not removed surgically. Histologically, there is necrosis with smudging of the tissue. The line of separation consists of inflammatory granulation tissue. So if you see the line of separation, if you take the tissue from the line of separation and we can see in the microscope, we can see inflammatory granulation tissue there. So these are the features, differences between the dry gangrene as well as wet gangrene. We know that dry gangrene we can see in the limbs, wet gangrene is most common in the bowels, hollow vessel. And dry gangrene, the mechanism of action is it uproots arterial supply. In case of wet gangrene, it blocks both venous drainage as well as arterial obstruction. So macroscopically, the organ is dry, shrunken and black in case of dry gangrene, and the organ is partly moist, soft, swollen, rotten and dark color in wet gangrene. Whereas putrefaction, it is limited due to very little blood supply. Whereas in case of wet gangrene, if there is so much amount of blood stuffing in the organ, so there will be no putrefaction there. And line of demarcation present at the junction between the healthy and gangrenous part in dry gangrene, whereas in wet gangrene there is no clear-cut line of demarcation. That is the important feature, demarcation feature between these two. And the bacteria will fail to survive because there is no blood supply there in case of dry gangrene, whereas in case of wet gangrene there is numerous bacteria present because of the abundant adequate blood supply. So in case of prognosis, it is generally better due to little septicemia. Prognosis is poor in case of wet gangrene because of the toxemia. So this is the specimen in our laboratory. This is the gangrenous foot. It is a below knee amputation specimen. You can see the toes all are black colored and mummified, and there is clear cut line of demarcation between the black mummified area and the healthy normal tissue. So this is the notes regarding the specimen. This is the specimen of below knee amputation of legs showing mummification and blackening of toes. And there is a clear-cut line of demarcation between gangrenous area and normal skin. So the diagnosis is dry gangrene. So coming to the next one, that is MONCKEBERG sclerosis. So deposition of calcium salts in tissues other than osteoid or enamel is called pathologic or heterotopic calcification. So two distinct types of pathologic calcification are recognized, that is dystrophic calcification and metastatic calcification. So dystrophic calcification is characterized by deposition of calcium salts in dead or degenerated tissues with normal calcium metabolism and normal serum calcium levels. Whereas in case of metastatic calcification, it occurs in apparently normal tissues and is associated with deranged calcium metabolism and hypercalcemia. So dystrophic calcification is the calcification seen in dead or degenerated tissues. So first we can see the calcification in dead tissues. Later we need to discuss about calcification in degenerated tissues. First, calcification in dead tissues. So caseous necrosis in tuberculosis, it is the most common site for dystrophic calcification, and the bacilli still live within these calcified areas. And liquefactive necrosis in chronic abscess may get calcified. Fat necrosis following acute pancreatitis or traumatic fat necrosis in breast result in deposition of calcium soaps. Gamma ganglion bodies in CVC of the spleen is characterized by calcific deposits admixed with hemosiderin on fibrous tissue. Infarcts may sometimes undergo dystrophic calcification. Thrombi, especially in the veins, may produce phleboliths. Hematomas in vicinity of bones may undergo dystrophic calcification. Dead parasites like hydatid schistosoma eggs and cysticercosis are some of the examples showing dystrophic calcification. Microcalcification in breast cancer detected by mammogram. So in all these cases, the serum calcium levels are normal, within normal limits. Even though the serum calcium levels are normal, there will be ectopic calcium deposition within these tissues. Coming to calcification in degenerated tissue. So dense old scars may undergo hyaline degeneration and subsequent calcification. Atheromas in the aorta and coronaries frequently undergo calcification. MONCKEBERG sclerosis show calcification in the degenerated tunica media of muscular arteries in elderly people. So today we are going to discuss about this MONCKEBERG sclerosis, which is the calcification within the tunica media of the muscular arteries in the elderly people. The stroma of the tumors such as uterine fibroids, breast cancer, thyroid adenoma, goiter, etc. also show calcification, and goiter of the thyroid may show presence of calcification in areas of degeneration. Some tumors which show characteristic spedules of calcification called samoma bodies or calcospheroids such as in meningioma, papillary serous adenocarcinoma of ovary and papillary carcinoma of the thyroid. And cysts which have been present for a long time may show calcification of their walls. Example, epidermal and pilar cysts. So coming to MONCKEBERG sclerosis. It is also known as MONCKEBERG's medial calcification because there will be calcified area seen within the tunica media of the arteries. It is a rare and low prevalence disease of the unknown cause in which small and medium sized arteries suffer calcification of middle layer, that is tunica media, leading to a reduction in the caliber. So this is the Monckeberg arterial medial sclerosis, which we can see the lumen which is filled with blood, and the tunica intima is uninvolved, and there will be blue colored, thick blue colored pigmentation seen within the tunica media, in between tunica intima and the tunica serosa, that is tunica media, and there will be, this is the calcification. So microscopically we can see basophilic, hyper and granular pigmentation deposition. These are the other pictures. We can see the Monckeberg's arterial sclerosis, medial sclerosis. This is the calcified area within the tunica media, and this is also calcification seen within the tunica media. The next topic is calcinosis scrotum. Calcinosis of scrotal skin is also known as cutaneous calcification or calcinosis cutis of scrotal skin. It is also an example of dystrophic calcification. It is an uncommon benign condition characterized by the presence of calcified nodules in the scrotal skin. Most cases are thought to arise by dystrophic calcification of the burnt out cyst. So previous burnt out cyst will ultimately lead into dystrophic calcification and nodule formation. That is usually seen in children and adults. The scrotal skin contains multiple soft to hard marble-like nodules ranging in size from a few millimeter to several centimeter. The overlying skin may get stretched and ulcerated, causing oozing of chalky material, and these nodules are filled with the chalky material. So this is the scrotal skin, which is showing the nodules, multiple nodules of varying sizes, which are filled with the chalky material. These are hard nodules. This is the specimen in our lab. This is the notes of the specimen. This is the specimen of scrotal skin measuring 13 into 7 into 8 centimeters. Surface shows nodularity. So we can clearly see the nodularity of the surface of the scrotal skin. And this is one big nodule, and this cut surface of this big nodule. So multiple. In this picture we cannot see clearly. Cut surface shows multiple chalky white areas of size 0.5 to 1 centimeter. We can see there. So the diagnosis is calcinosis scrotum. So calcinosis scrotum and dry gangrene, these two specimens are there in our lab. And there is a slide of Monckeberg's arterial sclerosis. So take down the notes or take the screenshot of these notes and enter in your records. And you also need to draw the diagram of Monckeberg's sclerosis in your records. So this is the end of the class. You can exit.